Everybody for joining us again. We have been doing this for a year now. Dr. Ayati, it's been a year since we've started these town hall meetings. And I always have had it in mind that I wanted to discuss with you your testimony before Congress in 2018. It's been in my office. I hand it out to everybody I can. I think it's so educational and helpful because it gives us a big picture view of aging in America. And I've always considered it the State of the Union address on aging and caregiving in America that no one's ever done before. Now, I used to live on Capitol Hill. I lived right across from the Capitol building. I was a social worker there. I was a photographer. I photographed in those rooms where people meet and testify. So when I saw that you had presented this information and I read it, I thought this was amazing. So I wanted to start this morning by just asking you to share with us, how did it come about? How were you invited to do this?
Well, thank you so much, Paula. Good morning, everyone. And again, so pleased to be again with Avenida's group. It's been years that now I've been invited as a guest speaker, and I'm so pleased. Again, such a wonderful and motivated group, and especially you, Paula, is for coordinating all this good things and for especially interesting topics, bringing the good speakers on board. And one of the things I have to say as a comment is that since we started the pandemic last year, it's been a wonderful educational resources for many of our older adult people, this webinars, and I'm very pleased that you guys are keep doing it, and I hope that the thing's going to be in person very soon. No, back to your question again. Thank you so much. I appreciate it for the comments. The way actually I was introduced to the group is from Senator Susan Collins, that she was at that time the chair of Special Committee on Aging, and her team actually was, they found me. It's very interesting that they found me, that I've been working on this subjects, and there've been they have a sessions that they want to have a hearing, and they wanted to kind of reflect about discussion about aging in America, and especially what should we do to promote healthy aging, and also address the different situation that related to the aging. And it was kind of like a very short notice for me to be there, but everything happened so fast, and it was really difficult time, because I remember that was exactly at that week. There was a fight between the Capitol Hill and government. They want to shut down the government at that time. And then they delayed it, they postponed it, they finally confirmed it. But actually it was great. I went there and I met with senators that were been a part of the Special Committee on Aging, and it's very interesting. And I was hesitant, honestly, to go first, because I'm not when it comes to the word of politician, I'm not going to come to my category as like a physician and somebody that just taking care of the seniors. But it was a very good experience. And again, even after that, I continued to communicating and working and advising. And it was good to hear that now they understand that it's a problem, and we need to do something. This is exactly what we're going to talk. And I remember that I came to Avenida's on 2019, I believe, on your a yearly conference, and we discussed exactly about the aging and challenges that we have. And this is ongoing. And again, this is one of the things that we talked today. I think pandemic actually showed us that that yes, we have a real problem. And I'm going to make a comment that actually showed us that the dirty laundry of many of our healthcare system came out in front of the public eyes. Something that when we talk about it, the people never pay attention, that yeah, that can be very serious, but it is very serious, and it will be much more serious in the future. Yeah, that's why that's the way that I went there and I work with them. And I know the members of the team there, and we've been, especially during the pandemic time, we've been chatting and communicating and try to provide any information and things that they needed in order, because they have also many series of discussion there. But again, I'm so pleased to have this collaboration and network there. And again, I wanted to share, as Paula said, about the challenges that we have. And part of that, you've been on my 2019, but I wanted to just quickly review and remind you about what we discussed a couple of years ago and why it is actually more kind of like very, very pronounced today, especially after this pandemic. And this is why Paula and I were talking about it. Maybe that's a good topic that we have a reunion about this topic and conversation. With saying that, Paula, we were ready to go through the slides and discuss, or anything else that we want to talk before?
No, let's start with your presentation.
Okay. Sure, absolutely. Let me go to here. And I want to do this. Let's do slideshows, and here we go. You see my slide, aging, pandemic, and future?
Yes.
Okay, perfect. Here we go. Okay, yeah, that's something that, what is that? It's coming to listening. Here we go. Let me stop that. Let me just a second. Okay. No, the challenges of human, it's something that is, we know it, and we don't want to talk about it in details, but if we put it everything from Second World War till today, we have a tremendous disasters coming out since World War II. I mean, from the war till today, we have many things happen in the politics, but I think after 1945, the major things happened was the recent pandemic, and that was a big shock for the entire planet and showed us a loss of deficiencies that we have, especially in our healthcare system. But one of the biggest challenge that we have, before we come to the challenges, what other things that happened to us which was positive, that we have massive advancement in technology. That has been extremely helpful when it comes to the daily life. I mean, because of this technology, you and I able to see each other even in the middle of pandemic. Think about that if you don't have this a platform of technology and we facing this pandemic, it was been extremely difficult for all of us to communicate. I think thanks to technology, because it made the pandemic to become much easier. Stay home much easier. The kids able to go to school through this technology advancement and be able to communicate with each other. And this is one of the topics that I wanted to talk about it later today, that how important is this technology. But the medicine also has been evolved through the years. From a basic pharmacy that they are mixing the medications together, and the old days we have pharmaceutical companies, and it has been very helpful for human. The effect of that we see today in the vaccination. The vaccination for coronavirus is just happened just less than a year that we got vaccine development and we got authorization. And that was been showing that how successful we are in some of the medical technology and especially advancement and development. One of the comments that I make here, that what we've seen in especially with the Pfizer and Moderna vaccine, and even AstraZeneca and other vaccines that also in the other countries that they are effective and they're working, it's we never seen this union that all governments, pharmaceutical company and participants, they come together. One of the reasons that we're able to have this vaccine so fast, it's not because they bypass all the safety protocol. No, because for drug development and vaccine, the money came to the pipeline, participants, lots of voluntary people, like for Pfizer, 45,000, Moderna, 30,000 people. And this is the thing that it showed us a lesson, that even in the future, if we have government organization, people, science, and researchers all together, we actually able to solve many diseases, many problems, again, including dementia, including Parkinson's disease, including many of the diseases that is kind of like frustrating. But that happened, this experience, we saw it when we have development of the vaccine. And I think there are some points that we need to learn. I have some in my last slide, but I just want to say that having this massive technology and having this rapid progress in the medical field was not all the time negative. It's actually positive if we use it appropriately. And again, the surgical team and everything has been very helpful. However, I think at one point, the pandemic showed us, despite very advanced in medicine, we still have a lot of gaps. We still have a lot of deficiency that we need to fill. When it comes to aging as a new challenge, which we talk about it, is the challenge, it comes more as far as like economy, as far as like what should we do with the entire society when we have aging population from 1950 that has been growing to 2050, which is going to be a significantly higher and higher. As you see probably here, that there is a significant decline from 1950 to 2050 from the people aged less than 5 versus the people aged more than 65 around the world. And that's just true. We see that the population that over 60 will be double. And we technically going to reach to 2.1 billion from 759 million today. We're going to reach to 2 billions of people above 60. And well, there are many things that's happened. We have lower mortality rate. We have an increased lifespan. That this is something because sanity, again, medications, prevention of infectious disease, cardiovascular disease. There are many factors that actually happen that we have increased lifespan in our aging population. But definitely decline immigration rates, lower fertility rates, many other things that actually cause that we have more shift toward more elderly people in the population. And again, one of the things that we are projecting that actually what we call it old geriatric population, which is going to be 85 above, which is going to be significantly 151% from 2005 to 2050. That's going to be significant. It means majority of people going to be around 95, 100, 85 and older. And that's a positive thing, but we also have to keep in mind that we have to prepare and make sure that we are able to provide services for these people, because this category age, especially 85 or older, is going to be more likely coming with some of the geriatric syndromes. And then for addressing the geriatric syndromes, we need to have, this is exactly the topic we need to talk, that we need more resources, we need more education. I think we talked about this in 2019, I brought it up again, that why the politicians are worried about that. And there is a reason that they are. If you look at this data from Africa and Asia, especially Africa and Asia, and you can see the trend between 2015, 2020, and 2030 above, you will see the number of the people that they are younger is just going to be much less and less and less. And that's significant, especially when you look at the Asia and Africa. That's kind of scary. And the reason I'm saying scary, because 20 years from today or 10 years from today, even in Africa and Asia, the number of the people who are younger will be less than the people who are older. And that's going to be a problem, because historically we are hiring the caregiver, or we are importing the caregiver from this area, especially Asia and Africa, to this country to take care of our older adult people. The same thing in European country as well. Now, this thing is going to be problematic, because if by definition in the next 20 years, if they are going to have less young people, that means that they are not able to come to the Western countries and taking care of the many older people here. And that's going to be extreme problem in the future to finding the caregiver to taking care of the older adult people in the Western and developed countries. That's going to be a huge political and issue, and it's just going to make this lot of regulation change in the countries, especially for immigration. As you probably, I think I shared with you that in 2018 and 19, many of the European governments, they changed their immigration law. And they actually, for the first time, after years, that the number one specialty that they want to be software engineer, computer engineer, they actually changed it to have a caregivers to take care of their older people. That's the number one priority if somebody wants to migrate it to European countries right now, because they have a problem. Germany has a significant problem with providing. Italy is the same. Now, that things is going to tell us something that I think I shared with you in the past, that expectation is that, or estimation is that in the next 10, 15 years, the salary and money that we pay for caregivers will be much higher than even providing the salary for a registered nurse and even primary care physicians in the society and communities in the future. And it will be extreme, the same thing that we have. Like, for example, you remember that how difficult of finding masks in the beginning of pandemic. There was the fight between countries to find just a simple mask and gloves. And that things it will happen to finding caregivers for older adult people, and that fight will be going on. And that's something that a lot of people, they think about it, and a lot of the politicians are from 2012. It came to their table, and they are seeing that. That's why they are trying to adjust and change a lot of the law regarding immigration. That's the point that we want to see what's going on with the future as far as like the politics. But beside of that, what we see today, which is kind of concerning, is that we are dealing with the society that extremely medicalizes, and medicalization of the society is one of the big issues that we are facing with aging population. I talk about it every time when you invite me in any place. I always say that, because one of the things that we keep in our mind that everything is fixable with just couple drugs and medication. We saw during the pandemic that that's not true. Even with the small virus of the coronavirus, even till today, none of the medication has been helpful. We didn't have a still magic bullet that technically killed the COVID-19 viruses. It's combination of luck and your immune system, if you're able to survive. If not, then it's, again, there's a lot of medications are available, but none of them, they actually kill the virus. They may reduce the hospitalization in some cases not. We still have mortality. It's showing to us that fixing everything is not answer, is just a procedure or medication. It's a really big picture of the physiology and body that we need to really put everything in context when we talk about a disease, when we talk about the syndrome. It's not about that, for example, Dr. Ayati come and say, I'm going to write for you 5 medication as of today, and I will see you in 1 month and you will be better. That's never going to happen. We know it. It's a lot of other factors are involved when it comes to the human physiology and body, and it's not everything can be fixable. The procedure-wise is the same. Even we have a very advanced heart transplant, lung transplant, very advanced ICU. We saw just during the pandemic that how our ICU sometimes can be incapable around the world to even taking care of somebody with the acute respiratory distress syndrome. They've done a magnificent job. They've done all the ICU team, they've done their best, but we found that we're still so behind when it comes to the very critical situation. And still, we don't have knowledge. We cannot fix everything just by ventilator machine and some of the medications and other resources that we have. It's just more beyond of what we were thinking about in the past. Now, based on that, I just want to say, are we ready to taking care of this population? Is this population is going based on the numbers that we have? Do we have enough resources or not? Again, what we've seen during pandemic, it was kind of like a good eye opener for all of us that we still need to have more education, especially more resources, more specialists, more people that they understand and they know about a specific thing about aging population. And this is what we're talking about. We need to have more. I'm not saying the geriatrician as only physician, but also what we call it about geriatric healthcare workers, which including doctor, nurses, social worker, physical therapists, occupational therapists, speech therapists, and you just name it, even geriatric pharmacists. We need to have an entire umbrella of the geriatric workers to understand the aging population based on the change of their structure, physiology, and this is what they can manage the multiple comorbidities, understand the health management, and that's very, very important thing, because the management, it's probably much more important just cure, because sometimes we found that we don't have cure, like COVID, we don't have cure, but we just try to manage. I mean, even the people get the COVID-19 and they get to hospital, they only manage them. They don't cure them. And that's something, even with vaccine, we are managing, we're not curing. We're just managing to prevent more severe disease. We are extremely shortage of geriatrician right now. Sadly, in the next 2 years, we have thousands of geriatricians will be already retired. As just a physician, I can talk. And or fellowship programs, we're not able to meet the, again, the shortage that we're gonna have till 2030, which is only 9 years from today. When I was speaking about in 2015, I said, well, we still have 15 years, but now it's 2021. We only have 9 years. And we're still so behind to meet with what we needed. But we're not going to get it. There's no way that we're going to meet that shortage. But we have some possibility that we provide education and train and educate other physicians that they will be advocate for them. Now, one of the things that we know, which I always said that, you know, our medical system, it's based on diagnostic and treatment. Again, that's a very funny cartoon, but you don't need a colonoscopy, but I'm sending you because quite frankly, I don't like you, as the doctor said, but technically we're so diagnostic driven practice. When you go to the doctor, we just check the blood pressure, we're just running some blood tests, we check your cholesterol, your diabetes and all this stuff, and that becomes a norm. And rather than we really look at the entire picture, that, for example, that person, maybe even a lot of the medical diseases the person has is not only because a blood pressure is high or diabetes is bad. Maybe there is a component of mental health is involved. Maybe there is a component of frailty involved. Maybe there is many other factors. Maybe that person is really not comfortable and or not doesn't have a good environment around. Is not interactive. Has a very isolated life. And as a consequence of that, everything is going wrong, because what we see in physical health is reflect and mirror of what is happening to the brain and mental health. This is something that we should have this connection with each other. And when I see somebody, diabetes is not controlled, blood pressure is not controlled, patient is just getting more frail, that means it's just beyond of metabolic syndrome. It's just a big umbrella. But what we do, we just do very quick diagnostic and do the test. And then finally, we ended up with medication. And that's something that we just say, okay, well, for blood pressure medication, you should take this one. For diabetes, you should take this one, just take this one, and then come back to see me in 2 months, 3 months, or 6 months. If it's, and again, 2 to 6 months, we go again to the same. Rather than we just say, maybe there are some other factors that make the patients to become more frail. We can prevent, we can manage, and we can do something. I always make this, it's part of my book, Paths to Healthy Aging, and one of the cartoon there, that the doctor saying to patient that the problem is you're over-medicated. Luckily, there are drugs can help you with that. That's a sad story. That's a real story. I know it's a joke, but it's a real story. We are, sadly, I mean, including myself. I'm not saying that I'm not, every physician, we've been trained technically to just do diagnostic, therapeutic based on medication. And then when we have this pattern, we are always giving the medication to subside the side effect of other medication that we prescribe, rather than we stop the medication first and say, okay, many symptoms that you have is related to the medication that you had in the past. And we always saying and talking about it, and this is the problem. This is not only about medication that we prescribe, even nutraceutical, which is kind of comes to vitamins, supplements, and many other things. The people are overusing them. And remember that even despite of we saying that against COVID, none of them is important. I've seen a lot of information coming to the media. Oh, everybody with COVID should take zinc, should take vitamin D, should take vitamin A. And I just remember this, what a report they say the shelves of vitamin D in the stores are just empty. And the people are taking lots of the supplements or vitamin C in order to fight with it. We know till today that none of them has been really effective. There's a lot of theory behind it, but when none of them comes to the action that this is true, this has been well studied, this shows the prevention is effective. But not only that, nutraceutical, we're talking about $68 billion market every year. And when you go to any store and see this all vitamins, supplements, herbal medications, whatever you call it, which is over the counter, they are not. They are in the very, very again nice and beautiful bottles. It's very attractive. When you look at the internet, they said, "Oh, this is the solution for you. That makes you sleep better. That makes you feel more energetic." But honestly, there's really no study behind them. And if you look at the bottle, is all of them, they said is FDA regulation is not there. It's not regulated by FDA. Take by your own risk. And when we have this comments in any bottle, means that the manufacturing of this product, they don't need to prove any study in order to make it to the market. They can do it with your own risk, and you just take it. And again, I'm not saying in some people, maybe some of the supplements is working in some people, but it doesn't mean that it's generalized. That means it doesn't mean that it's going to work on your neighbor as well. And the problem I have with them, that they are having the same effect that other medication they have. They may cause side effect, they may cause interaction with medications that you're taking, and also financially, a lot of people just wasting their money for that. Now, when it comes to healthcare, that's true. We have a lot of issue with our healthcare system, and that's what we want to talk a little bit about, why our healthcare system. This is part of the discussion that we have, even part of the hearing in the Senate as well. One of the things we have, we have a tons of spending. We know it. I mean, everybody know it, that we have a tons of spending. We are the country that we spend a lot of money for healthcare. And we saw that we didn't have a very simple mask in this country when the pandemic happened. Or we have a loss of shortage with the basic stuff in our healthcare, as far as and I have a conclusion for that what did we do wrong in the last years that we had this crisis in the beginning of pandemic. But however, we have a significant health spending accounted for 16.4% of the gross domestic product in 2013, and is projected in 2020, just last year, to be 20%. And again, in 2040, estimated of 1/3 of all spending in the United States will be healthcare. It's not far. We're talking about 19 years from today. 1/3 of all spending of United States spending will be healthcare. This is absolutely correct. Just think about the number of the aging population that I said, all the chronic diseases that we talk. This is absolutely going to happen. And this morning, when we had a grand round at Stanford, exactly was discussion about the healthcare spending. And that's going to be a majority of money that every year that we're going to spend will be on healthcare if we have the system. Now, the problem is that we are in the country, we actually spending less on social services. And we technically spend more on the treat people after they become ill, which is going to be the same thing as I said, more about medication, more about the complication, but what about the social services? What about the necessary need that they have, especially for aging population? And in United States, compare of other developed nations, again, many of them, they're not able to do it because they cannot afford the cost. And what we see that in 2002 to 2012, 54% of people with chronic diseases, 8 illness reported the cost was a barrier to them to get access. Now, when it comes to the older adult, that's a very simple thing. Older adult, they have more chronic diseases. Definitely high blood pressure, everybody has it. High cholesterol, everybody have. Osteoporosis, maybe diabetes. That means that we have more resources, more supportive help. And again, usually older adult living with 5 or more chronic diseases. And again, that's something that's just going to be significant. They see 50 prescription, 40 different physicians, and make 37 office visits per year. And that's something that we think about it. The multiple chronic condition, 71% of total healthcare spending in the United States. That is significant. And again, what we have is just chronic diseases. 75% of Americans 65 or older are living with multiple chronic condition, and 20% living with 5 or more chronic condition. And that means more medication, more resources, more office visit. Now, one of the other challenges that we have, it's about dementia. Dementia, till today, we have no treatment. Even we have seen some new positiveness in some of the pharmaceutical, but it's still, we haven't seen the green light, or at least a small light at the end of this tunnel. And what we're expecting that the number of the people with dementia will be triple in 2050. And think about the cost of the dementia care, which is significant, expensive. Many of you have a loved one in your family, and you know how expensive it is to taking care of a person with dementia. With no treatment, with a lot of other factors are related in dementia that needs to be addressed, dementia will be a huge challenge for human. And I will say majority of that health spending money that we talk about it for older adult will go toward the managing of dementia. Now, when we talk about healthcare spending, there are some reports, like for example, Institute of Medicine, they found it in like 2010, that 2010 report in 2012, that technically 210 billion we spending on unnecessary services. Institute of Medicine reported that 555 billions on the other side is just other wasted spending, which have a non-overlap with each other, and then the 250 billion. And that's significant. Technically, what we're doing, 30 cents and 40 cents of every dollar that we spend on healthcare is spending on the cost of the poor quality, and trillions of dollars a year. We are actually technically spending on overuse, underuse, misuse, duplication, and failure, unnecessary repetition, communication, and insufficiency is not coming from me. It is true that we are spending billions of dollars for many unnecessary services. I shared this story with you, and I want to share it again with you today. But one of the story that it was real and happened to me, and it was exactly at the beginning that I started my work in Bay Area, and it was an old gentleman, 92 years old, that he had a very severe advanced dementia, and he had a colon cancer, but family decided to not proceeding with treatment, and he was in boarding care house, and he fell down. And what happened is that they took him quickly with 911 to emergency room. They found that he has bradycardia, which means a slow heart rate. He was quickly transferred to cardiac lab, and they put the pacemaker for this gentleman in the morning. And he was extremely delirious after he came up from the procedure room. He was agitated. He was throwing this stuff on the staff. This is why they call me as a geriatrician to go and see him. And it's when I was trying to calculate that, what was the reason that we wanted to put the pacemaker of somebody who has already very advanced dementia, and it's kind of like he was a definitely hospice candidate at that time, and we wanted to put a pacemaker for this person to do what? If somebody is even not walking, what is the point of putting the pacemaker, which is costing thousands of dollars? And for the gentleman who unfortunately, because of procedure, became more agitated, more delirious, and we had to give him a lot of psychotropic medication to calm him down. And he sadly passed away so quickly, just 4 weeks after that event. When you come to this calculation, you really don't understand $100,000 that we spend on placing a pacemaker. It could help a lot with this family to provide services, caregiver, maybe take him to a better boarding care facility. That even help with the copay of the medication that he's taking. They can provide 24-hour caregiver for the last weeks of the life for this gentleman. A lot of other resources that you think about, equipment, the same thing that I talk in my next slide. There are many, many services are so helpful and essential for older adult people, but we do not spend money on them. We spend money easily if we want to do MRI, if we want to do CT scan, if we want to do any procedure, we just quickly, we just in one day, we get authorization and we do it. But if we want to get a wheelchair, we're going to have a hard time to get a wheelchair from Medicare. You have to do like papers of documents and to see if the wheelchairs is helpful, necessary or not. Providing the caregiver, hourly basis caregiver for families that they cannot afford to pay the caregiver money. What about if these services will be provided, this money will provide for social services that they need? Having the social worker, having the counselor, having psychotherapists to help them with anxiety and depression. None of these services is very well paid by Medicare, and some of them they don't pay for it, or even transportation. Many, many things that you can, if you just want to do a checklist today, this is not a rocket science. You can easily find and write a note that what are the services can really help the quality of life of families of older adult people, and even older adult people with quality of care. That means if they see Ayati, it doesn't help them. If they go to do MRI, it doesn't help them. But if I can provide some resources and support, they can help them significantly. The sad story is this is a global problem. This is not only in this country, but I share with you, and I put it again by purposely, because this is still the problem. In probably, you know, that in 2019, there was a very sad news release internationally, and it was from BBC World, that many older adults in Japan, they intentionally do crime to go to jail because they don't have any money to take care of themselves. And the retirement money is not answering what they need and what their needs are. It was a very sad story. I just got a quote of that from there, that I took a bicycle, rode to the police station and told the guy there, look, I took this. And sad story about it, if you like it, is still there. You can look at the internet. Many of them, when they release from the jail, they do intentionally crime to go back to jail again. Technically, it's there. Not only that, in many of this country, especially Japan, many older adult people, in every single seconds that we're talking to each other, they committed suicide in front of the high-speed train because life is extremely difficult for them. It's not only there, many of the places is the same. We are facing a lot of challenges in the world. Resources is not there. Now, the reason I brought up this story, because when you look at this data, countries in Asian countries, and I actually had a presentation for Age Asia in end of the 2020 for Singapore, and I actually discussed about it with the Asian partners about that. A lot of countries, China, South Korea, and Japan, they are spending billions of dollars for anti-aging market. That's sad. Many of aging population there, they are dying of the lack of resources, or the same story that I share with you. But we are spending, even in the United States, $271 billion in 2024, 3 years from today. the market growth of anti-aging products, which we are wanted to fight with aging, but for people that already age, we don't have any resources to help them. You know, the 1% of this $1 billion can change significant in quality of life of many older adult people in these countries. That's a problem that we are facing now. When it comes to crisis, unpaid family caregivers, that's a really, really big challenge. And again, I'm just, again, I'm not good on this numbers, but you know, this is from ARP, but a lot of the families, they get bankrupt for because they have a loved one, they have a mom, dad, or they have a partner, and they have to take care of them, and they don't get paid for that. And they and again, they cannot even afford that. That's why the average out-of-pocket expenses for long-distance caregiving in 2016, we just talked about 5 years ago, is 11,000. I'm sure the number is much better. But again, family caregivers provided $470 billion in unpaid care, which is another issue that we're facing. When it comes to politicians, the issue is just worse, because in the world of politics, if you can help me, if any of you during the presidential debate last year heard a single sentence about that we have a plan to help the elder care will be better during our presidential years, again, please email me and tell me that I'm wrong about that. But I haven't heard. I try to listen to debates. I try to listen to all the campaigns and see if there's any one single word somebody says, you know what, our country is facing aging population, and I want to do during my 4 years. Again, especially we have a president right now, both president and even the former president, they're both geriatric. And they're both in the category of older adults. And if there's any, and majority of the people in Senates, they're all also in geriatric category. But I don't hear that. And again, it's not only that, because we are, even in the world of politics, we are wasting our time for lots of subjects that is really not going to change the quality of life of people. Now, when it comes to COVID, I want to talk a little bit about COVID and aging and challenges, because it's a time for COVID. There's three things I'd like to talk about it. One of these economic setbacks that regarding the COVID for older adult, health and well-being effects, and ageism and racism that it comes with the COVID situation. When it comes to the economic setback, which is so important, the first people is always based on what we see in during recession that we have in 2008. When the companies are get rid of the staff, the older staff going to have a harder time to re-enter in the workforce again. Based on what we see that. And again, this is something that we see definitely as an age discrimination. It's happening. Sometimes the younger workers might fare worse with initial job loss, but technically older workers will fare worse in re-entering the workforce. And again, what we have in 2008, people of age 62 years and older were the least likely the age group to become re-employed again once they lost their job based on experience that we had. Now, the economy is back again to normal, and we may see these things again. Age discrimination always play a role here, because a lot of the number of the job applications, employers can apply a selection criteria when they do the hiring. Technically, one of the things is that if you are older, you always need to have a higher salary, and probably you may, because you have more experience. And again, that's something that they wanted to kind of like the employer, they don't like to look at it, especially even when you talk about retirement package and many other things. So many of older people, they're working because they wanted to make sure that they have a good retirement as well. And that's going to be some discrimination in this situation that happened. The other things about health and well-being effects. One of the things is during the crisis, we all faced the shelter-in-place order, which we all having. and closing the organization prevent many people that they have pre-existing condition, physical, emotional, social needs. They were not able to access to the healthcare system. And again, support services are jeopardized. Like, for example, the same thing we see, like Avenidas, they have to close that. The healthcare system, which was very narrow because they have to manage the COVID cases, appointment, procedure, and everything has been delayed. Regular checkup, non-urgent provider visit, elective procedure, they're all canceled. And again, that definitely put older people to higher risk of the worsening health deterioration for these people. And not only that, social isolation and loneliness, we talked about it in the past, definitely has linked to negative physical and mental health outcome, especially increased depression and anxiety in many older people that we know. Even before of the social distancing, social isolation was affecting older adult people anyway. This social isolation was just because of pandemic is just added more to that. And again, now when the other things is that most people who contract COVID-19 will see the full recovery, but the long-term effect of illness, especially in older people, still is not completely understood. And especially we may going to see some long-term effect of that. And this is why older people overall, they may facing more challenges with health and well-being effects, and especially regarding the anxiety and isolation that they have. One of the other things is ageism, racism, and classism. Countries were slow to respond because older people at risk treatment and mitigation protocol have been one thing that we see that children and young people, when it comes to hospitalization and when it comes to even nursing home situation, it's been the discussion from March 2020 that more resources and focus will be more on the young people. This is naturally is correct because that's been traditionally in human. Whenever we have resources, even with the traditional societies in the past, old tribes in the past, when they, for example, the camps they have to move, they always give the resources if they have like limited food to the pregnant mom and women and the children of that tribes. That's accepted. We not argue with that. But one thing we saw, which is going to bring up again the same flame that we discussed, which I'm going to talk a little bit, it's that when it comes to older people, it's kind of like a little bit shame and embarrassing when what we saw last year. There's still a lot of the stories will come because now we are, and I'm sure in the next years, you will see lots of reports and books about this pandemic, especially in 2020 and 2021. Number one is that because what happened in that time, I just wanted to remind you, go to the news, Spain, Madrid. In the middle of the crisis, the ambulance technically refused to take older people from their home or nursing home to take them to the hospital. They let them die in their home and the nursing home. That just happened a year from today, just a year from today. In Italy was the same. In epicenter of New York, when we had a crisis in spring of 2020, you know it in the news, go and search it again. Many of ambulances, when they get a call in New York, if they know the patient is older, they don't go and pick them up. They actually was just waiting to get the younger people because they were so overwhelmed. We see that ageism happen. We saw it with our eyes. There's no more explanation of what happened. But on the other side, we've seen that. We see it in the news as well, that we also saw the racism as well. Older African American, they always have the higher rate of morbidity. They have less access to the healthcare ongoing to the crisis. And the other things is that what we talk about classism as well, that many of the people that they don't have money social isolation was very, and in home order, it was very difficult because many of these people, they have type of job that they have to go to work. They cannot stay and work with the Zoom. They even don't have computer to work with the Zoom. And that brings these issues with the racism and classism that we've seen that. And again, nobody can deny that. We've seen that happened in 2020 till today, not only United States, all around the world. And that happened. That shows that how behind we are as really standard in even 21st century, even when it comes to the crisis related to aging. We saw this when we talk about chaos that happened in the nursing home. I'm not blaming nursing home that they've done wrong. The reason I'm saying that, because when it comes to resources, governments, which is a state in like California, they are not providing necessary services for a skilled nursing home. They asking them to run like a medical surgical unit without resources, without training. Many of the staff in the nursing home, they haven't been trained very well to understand anything about outbreak, infectious. They don't. I'm not saying that this is their problem. Yeah, corporation of nursing home, they need to be revived. They need to kind of like revolutionize. They need to be changed. I hope that we learn this lesson from this pandemic, because we had tons of mortality from this nursing home situation, not only in United States. Even as you remember, in Europe, about 51% of the death of entire European countries was actually the people in the care home and the nursing home in Italy, Belgium, UK, Germany, and everywhere. Now, even in the country, in our country, majority of mortality that we have so far today was related to the people who are living in care home, which is assisted living, nursing home, and boarding care. There is a problem there. Nobody can ask her. I will say dirty laundry of these places for after many years came to the front of public. But I hope that we do not forget that. I hope that now we know there is a problem, rather than we blaming each other that, oh, that was your fault, that was my fault. We come to conclusion, because these places, they are going to serve our future aging population very soon in the next years. We need to improve their system. This is the lesson that we need to learn. A positive lesson that we learned from the COVID, which can be very important for aging population, people become more united and caring. I've seen that more, especially the beginning of pandemic. The neighbors for the first time calling an older neighbor and ask them, do you need something for shopping? This never happened before. Maybe happened in the single, sporadically, but we see that these things is happening more in our society. We found our deficiencies. The deficiencies that we found, that we cut significant amount of money for research. This is the first time we saw that how much important that in the country we have doctors with the specialty of infectious disease. The infectious disease doctor, they're very underpaid in the healthcare system. We pay more to the surgeon, but not infectious disease. How important that we have more infectious disease doctor in the country, that we pay them better, we motivate them. The same thing for having a geriatrician as well. How important to be geriatrician, to be on board, to take care of the older people when it comes to crisis, when they take care of the or older people in the nursing home and the facilities. Research, the country who's been #1 in research had a hard time to providing even the mask, gloves, and guns for their own healthcare staff. Everything has been outsourced. All the research lab has been outsourced. We should sit after this pandemic and all together think about it. What was wrong? We need to do something, because COVID-19 is the first pandemic that many of us that born after 1918 we see in our life, but it will not be the last one. It will be more of pandemics going to happen. There will be more outbreak, even local epidemic and outbreak is going to happen. And definitely the people learn about precautionary measures. Now, before the pandemic, when we put the mask in front of our office or when you go to the hospital, there is a gel and there is a mask in front. Nobody cares about it. It says, if you have a cough, if you have a sneeze, if you're not feeling well, please put the mask and clean your hand. And everybody just ignored that sign and come to the building, and they spread the virus to everyone, flu at that time or rhinovirus for the cold. But now people learn. Now people learn that it's important to clean their hand. It's important if when somebody is sick, definitely protect other people, put the mask on. Even you don't have COVID, you may have other illness and dizziness. Definitely, one of the things is so important is technology skill in older people has been significantly improved. Before the pandemic, there was a kind of a steady growth in the number of the tech-savvy older people. It was documented that 75% of people aged 65 older go online every day between 2013 and 17. When they look at the smartphone ownership, they see that it increased 24% in the people 65 older. And we saw the need. I mean, look at today, video conferencing, and now even people ordering groceries, exercise classes online, talk to the group of people. I mean, there are coming that what we need to do is definitely we need to have a train and educate our older people to really use the technology for their well-being. And that's something that is actually we learned through this pandemic. One of the things that's been amazingly positive for me that it never happened before, family and intergenerational connection have grown stronger after this. It is very, very obvious that many families are finding the pandemic encourage them to more regularly communicate with each other. People felt the absence of family dinner. People felt the absence of celebration with each other. I mean, this is something that they never came to their attention before because it was there all the time. There are numerous stories that you read in the media about neighbors connecting, about family connecting. Like, for example, I was just looking at the New York Times story in 2020. It was a grandmother speaking with the grandson and two grandparents through the iPad every single day. And grandmother is reading the book for the grandchildren through the iPad story. This is wonderful. And again, as when it comes to younger people, it's coming to, for example, a lot of the connection with older people. You know, probably you hear about Zoomers to Boomers, intergenerational grocery delivery services. They're happening. A lot of young people, they go for older people and they buy purchases, grocery and many other things that can be very helpful. Older people, one of the things is outbreak is changing how we think toward our own physical and mental health. We have showing that, we see that how much important to have sleep, diet, exercise, social connection, and safe care skills are so important for daily basis. When we talk about it in the past with people like, for example, how important to do exercise, how important to have social connection to each other, I think now the people are facing, oh, I love the door is going to be open, that I can go talk to other people. We found that if we don't do it, we're going to have a significant problem in our physical health and mental health. And this is something we also the last thing I want to say that definitely people have been more aware about how important is advance directive. COVID made that we lost lives of many people. But one lesson that I think it was extremely helpful for human, for the first time, especially in the United States after Second World War, and even in many European countries, it showed us that death, it can be close to us anytime. And it's never been like that because, again, as I say, we have a very medicalized society. People found that it's so easy that you can get a very small virus and you can die. And that's so important that we are not protected. Despite of all the advanced medicine and technology, there is still possible that maybe the next RNA virus is going to be in the community, and we have a high mortality. For first time, for a lot of people that I know, that I'm never able to talk about the advanced healthcare directive and what they want in case if they become sick before pandemic. I got a lot of call from them and said, I wanted to talk to you about my advanced healthcare directive because now if something happened to me, this is what I want. This is my wishes are. I don't want it to be transferred to the hospital. I don't want to put me on ventilator if I get a very bad COVID pneumonia. Please don't do it. And that was extremely positive. I get a lot of call from the children of my patient that if my mom and dad, they get dementia, please do not do any invasive intervention if they end up with the pneumonia to the hospital. That was very, very positive. Now, I think it's important that despite of the vaccination, we think about that this is still a lot of other things can happen to us. And it's the time that we think about, yes, one day we may going to be incapacitated to really talk. We may not have ability to talk for ourselves. It's a good thing that we express our wishes to our loved one, to our physician, to people that if something happened to me, this is what I want. And that's something that COVID motivated. Now, the homework, I put it here because many things that I discuss is only between like 40, 50 people in this Zoom that we discuss and we learn from each other. But this messages needs to go to all people. This is our job to really discuss about all the crises and all the issues that we have. It's not for people that just link to Avenidas. It's just for everyone in this community. And I think every single of you, you have this responsibility to talk about it, to talk about everything that we discuss. Because again, one word, one place, it's not going to be enough. We have lots of challenges that we need to fix and at least manage for the future. And this is what I like, that every single of you be responsible to discuss about it, at least with your own family, at least with your neighbors, that we have a problem and we are going to fix that. Given say that, I mean, I'm done. I just want to thank you so much. I tried to just quickly review what the challenges and what the discussion we had based on what the testimony was happened. And I'm happy to answer the question. I'm going to stop my sharing and Paula.
Okay. We're going to invite everyone to post questions on the chat line. I have so many questions. And I do want to thank you, Dr. Ayati, for all the points raised. They have certainly been, I've seen them happen in my caregiver group discussions. Everything you've talked about, people seeing their primary doctors, not feeling comfortable with some of the answers they're getting, needing to perhaps talk to a geriatrician. Should they write a COVID will, a dementia will? There are just so many topics that relate. So you did a big picture conversation, but of course it relates to everybody's individual healthcare and if they're a family caregiver. And I think one of the things that people still don't understand to this day, maybe you can talk a little bit more about it, is, so what is the difference if I have an elder client and they're telling me about their symptoms and they're telling me they go to their primary doctor and they don't have a geriatrician, what would be the difference between having an intake with a geriatrician than with a primary family doctor?
That's a very good question. The primary care physicians are technically internists or family physician. A geriatrician are subspecialists. And like, for example, all of them, they need to be trained in primary care, and then they go to subspecialty of geriatric medicine, which is a fellowship program. They need to be board certified. Primary care physician are technically, the job is providing a primary care for your health and well-being. Like, for example, if you have a high blood pressure, you have diabetes and all this stuff, the primary care do. But when it comes to geriatric population, the things, even for example, you have the same issue with high blood pressure, diabetes, it will be more complex a little bit. And the geriatrician job is technically taking care of complexity of your health problem related to the aging. Primary care, first of all, there's no way that, in United Kingdom, for everyone aged 60 years older, they all go automatically to geriatrician. Even if you come to the hospital, to emergency room, you remember Dr. Elder was here as our guest in Stanford. We always chatting about it. Everybody, when it comes to emergency room in the United Kingdom, when it comes 60 or older, automatically the care will be transferred to geriatric team. And that's because they have good number of geriatricians in the United Kingdom. They train majority of their primary care doctor to be geriatric specialists. They understand about the complexity of the geriatric population. In this country, as I said, we cannot. I mean, we cannot have a geriatrician to be your primary care. That's the best model that is working is still you have your primary care physician, but you also have a consultant geriatrician on the top of your case. And the geriatrician can provide feedbacks to primary care physician and other specialists regarding your geriatric complex issues. Even it shouldn't be only dementia. It can be heart failure, it can be diabetes, it can be Parkinson, it can be neurological disease. But the point from the geriatrician that can help primary care and specialists based on aging situation, these are my recommendations, these are the things we need to do. And they actually work as a team on your case. You have your primary care, you have your geriatrician as a consultant, and they're both working as a team to help that person's going to have a better quality of life. That model, it's there. We have this model in this country, which means that we have primary care physician taking care of daily too. Like, for example, if you have a sore throat, you don't need to see a geriatrician. You can see a primary care doctor, can look at your throat. If you are infected, give you antibiotic. If you have urinary tract infection, you don't need to see a geriatrician. But if you have other situation is going on, like if you have like taking many medications and you have multiple issues going on, then it's nice to have your primary care physician that you see them routinely, but also geriatrician on the top of your case. You may see your geriatrician once a year or twice a year, or if you need it, like for example, every quarter, but geriatrician can help your primary care to navigate, to help you to addressing your chronic disease better.
Okay. I think you have a question about diagnosing and treating migraines. How do you treat migraine in 75-year-old patients who first developed this at 55?
Yeah, that's a good question. But again, I try to not answering clinical question here, but the treatment of migraine is it's very interesting. It's much easier in geriatric population compared to younger people. Overall, the migraine has a tendency to subside as we're getting older because of the deactivation of the probably neurotransmitter, which is in younger people, we have more peak of the migraine, and the middle age is going to be the time, which is like 55 years old. The treatment of migraine, it's the only challenge we have with treatment of migraine is the medications that we traditionally use to treat the migraine in people. The medications, they have kind of side effect in elderly people. That's why the protocol for treatment of migraine headache is a little bit different with younger people because of the monitoring the side effect of the medication. But there are some protocols that we are as a geriatrician we do it with the coordination with neurologists to help with the treatment of migraine headache. And overall, the prognosis and outcome of the treatment of migraine is always better in older people compared to younger people or middle-aged people, which is a little bit more difficult. But yes, there are, however, again, as I repeat, the medication that traditionally we use for younger population, we can use it, but we have to be extremely careful when we use them.
So thinking about the fact that many of us are now vaccinated and we're trying to consider how to lead our lives, are we to wait until they call for full herd immunity before we start going back to gyms or senior centers or adult day health centers? What's your thought on that?
Yes, the goal is always that if 60 to 70%, now a lot of experts, they say 70 to 80% of general population get vaccinated, that means that we are facing a herd immunity, means that it's less likely that we have a massive spreading of the virus in the community. We still may have some mutations in there and in one place, but that's okay. We're still not at that level. Based on what government is saying right now, that is going to happen in month of June. month of June is more likely that 60-70% of adults in the United States will be vaccinated. And this is the time that I think is much safer that, again, we go back again to regular life as we are expecting. Everybody's waiting. Even President Biden also said I think days ago that his goal is on July 4th, the situations will be much easier because majority of people, I mean, based on what the government is estimating, then I think June and July will be the time.
Okay. Are you still seeing patients in your office, or is it still all by Zoom?
No. We still see we see the patient. If the people are fully vaccinated, we see them in person. If some of them, they still, for the beginning of interview, we may offer for telemedicine to just get a history, but all the patient needs to come to the office for complete examination. Yes, we do. And again, if they are vaccinated, definitely we do. They come to the office and we see them. Yes, a majority of offices also in the counties are open right now. All the doctors are open right now to see their patient.
Okay. And if somebody is finding out at their own provider there's a delay in getting a neurology exam or a capacity exam, they could get that at your office?
Yes. They can ask for geriatric consultation. As far as if they have Medicare, we can provide this service for them. If they have Kaiser, we cannot provide the service for them because we're not a Kaiser provider.
Okay. I think there was a question that just popped up from somebody named Warren. Is it true that the vaccine does not sterilize any coronavirus that enters our nose or breath?
What does it mean with that? Again, the vaccine is technically, the job of the vaccine is there's two outcomes we are expecting from vaccines. And this is not for COVID vaccine, this is for every vaccine, even influenza vaccine. Number one is prevention from infection. That means technically, maybe your comment, when the virus comes to our nose or breathing, it will be deactivated and is not going to work. Technically, our immune system will be very active for mucous membrane and detect that and kill the virus, and we get rid of it. That's true. Second thing, which is the most outcome, that's what we're expecting from these vaccines, and majority of vaccine, even influenza vaccine that you take it every year, is preventing from severe disease. What does it mean? That people that even in phase 3 trial, even today, now we have more population is vaccinated in especially long-term facility and assisted living facility, that if they get COVID, they are not sick that they need to go to the hospital. That means that we reach to the goal. We are okay if the people get COVID and they only have asymptomatic or mild disease. We're okay with that. It's like a cold. Somebody get a cold and have a mild disease, have some cough, a little bit of fever, and resting for 2 to 3 days, maybe a week, and they get better and come back to normal life. That's fine. Nobody's scared of that. Even entire planet get a mild COVID, nobody's going to scare of that because we know that's fine. The scary times is that they go to hospital, they occupied ICU bed, they need ventilation. This is the time that we scare of the COVID. Now, it seems that both AstraZeneca and the Pfizer and Moderna vaccine, it seems that they are both done very well. Even in the report that we have from Israel, that they vaccinated majority of population. This is the first country that actually vaccinate above 70% of population. They already seen a number of hospitalization significantly low. That means that what we saw in Israel is just telling us that this is positive. That means that if we vaccinate above 60-70%, our ICUs will be empty. Now, every year when the people come and ask me, I don't want to take the influenza vaccine because every time I take influenza, I actually get influenza that year. My always answer to them is that, did you end up to ICU? Did you go under ventilator? And I said, no, I just was very sick for a week. I said, well, then that vaccine works for you. Because then that was the vaccine made you to not end up to get pneumonia and go to the hospital and be under ventilation machine. That means the vaccine was effective.
and this is exactly the same message for every vaccine, is not the job to prevent you from not getting infection. We have a very, very small number of the vaccine. They may give you 100%, but even measles in the kids, when you have 2 injections, you give them 97%. There's still 3% of kids can get measles, but it's not going to be severe. But overall, with all RNA viruses, not DNA viruses, RNA viruses, you never get full protection from the vaccine. And you may need to have booster vaccine in the future as well, based on the new mutations. But the job of the vaccine is make your body to not get very, very sick. And it seems to, so far, the both Pfizer and Moderna vaccine, and even J&J vaccine, there are providing this outcome. And this is why we're all happy till month of June, majority of population get vaccinated and be able to come indoors. We have kind of come back to life, but however, I have to tell you again, it doesn't mean that we have to exaggerate after everybody. We still have to be careful. We still have to respect to each other. For example, if somebody even has cold, make sure that even they not participate, or if they participate, they put a mask and politely and said, you know what, I have some cold, I don't want anybody get sick. That's why I just put my regular mask on. And I just keep cleaning my hands. That's something that people will learn. I hope that we will learn, because if we learn that, then I think we're able to even not having, like this year, we have very minimal influenza cases. That was a victory. It was, but influenza is always the most scary things when it comes to category of. I'm always scared as a geriatrician because my patients die of influenza more than anything else. And influenza is so scary this year because people are not engaging in activity, they're cleaning their hands, they're putting masks. We had significant low rate of influenza globally. That is going to tell us the story. If we follow the measures and precautionary measure, we're not going to have a problem with viruses in the future, respiratory viruses.
Dr. Ayati, here's a change of focus, and it's a great question. It kind of correlates to some of your last slides. How do you handle end-of-life decisions with your patients or clients and their families?
Mm-hmm. I mean, like overall, the discussion.
Kind of a general protocol. How would you approach? We can both talk about this if you want to start, because we've been distributing samples out of Avenidas of end-of-life advanced directives and wills that are based on, if I have dementia, what would I want, what would I not want, at what stage would I still want an antibiotic, what would I not? Also with COVID, there's new templates coming out for people as they think about their advanced directives. So if you have a family coming in, an 89-year-old with Parkinson's, and then they find out they have cancer, how would you handle that conversation? I think that's the question.
It's a good point. One of the things which I brought it up in the last slide as well, not only for this condition as COVID happened. The first thing I think we have to really think about it, which now I think the COVID made this shake as well in humanity overall. One of the things that I actually put it in my statement and that was actually on the floor. I was discussing that my suggestion is that everyone enroll in Medicare, they should have at the part of the enrolling Medicare and the wellness being a Medicare checkup discussion about advanced care directive at that time. It is very important. I mean, we know as a human, I know nobody likes to talk about dying. That's very normal. Nobody enjoys to talk about dying. But we've seen that. We are, as a physician, we see every day. Like dying is part of the life, and this is something that happens to all of us. It can be unexpected, it can be surprising, and it can be something expected that happens. It is very important that I encourage all my people that are younger geriatric to think about it much earlier. Think about what their value, based on their values, based on the cultural background, what they're thinking about the future, what they want, if the things can happen to them. And it's been very helpful to open up this conversation when the disease is not there. and they can talk about it. They can express their wishes. You know what, Dr. Ayati, I don't think that if I'm going to be at that level, I don't want to have any intervention. I live very well in my life. I'm ready to go. And that kind of open up the conversation, and we can discuss about that. Okay, well, let's talk about what are the things that you want me to do, or you expecting the medical team they do for you when that moment is going to come. And I'd like to share this opinion with your family. Now, this is going to be important, and I hope that at least through the COVID, people learn this, that yes, the people can die, even young people that nobody expect, they can die of the small nano, again, a small virus as well. And this thing can happen to any of us. But I say that when the disease happens, then it's a different situation. I think the one of the big issues that I can tell you as a geriatrician, that when the people come to me as a consultation, and that makes me very sad, the family of patients have no idea about what the disease that they're dealing. Like, for example, when we talk about dementia, they have no idea what the dementia is. And even the loved one has advanced dementia. They don't know what they're expecting to see. They don't know what does it mean in like a months, weeks, years from now, how they see the decline. And this is why they never open to them. They just say, okay, well, your loved one has Alzheimer's, dementia, that medication, good luck. And find a caregiver and taking care of that. That's a problem with our healthcare system, where people have no information about the chronic diseases. Like, for example, somebody has Parkinson's disease, they need to know that when the disease gets in advanced stage, what's going to be the quality of life. This can help them to make a right decision. If I have someone is in the mild stage of cognitive impairment, and I just say it's a possibility that persons may go to what advanced dementia or the moderate advanced dementia. Let's talk about it right now. This is the disease. This is the outcome. Then they will prepare themselves. They know what's going on. The same thing for cancer. When it comes to cancer, even the oncologists always say, okay, well, we're going to do chemotherapy. I always encourage or oncologists, a colleague, that also talk about that if the cancer treatment is not going to work, talk about if we fail on the cancer treatment, what's going to be the quality of it, what's going to be the situation. People have right to know about it. No, if everything goes right, that's perfect. We celebrate, we open the champagne. If everything goes wrong, then they know what they're dealing with. I think that's my point as a person who practicing geriatrics.
I'm going to have to leave, but Kat's going to take over the rest of the Q&A. I am now going to an Avenues board meeting, everybody, where I am going to be presenting a little bit on what we just learned from Dr. Ayati. So please, you're welcome to keep going. And Dr. Ayati, I'll be calling you soon for some other event. Okay.
Good to see you.
Take care. Thank you so much.
Thank you, Paula. All right, so it looks like we had one more question. I think that was, okay. Virginia asks, I had the second vaccination on February 19th. Should I wait to get the shingles vaccine?
14 days. 14 days after your second dose, you can get any vaccine that you want. That means, yeah, 219, yeah, you can get a shingles vaccine right now. It's more than 14 days. 2 weeks, technically.
Yeah. Perfect. I don't think we have any.
Good.
I don't think we have any other questions. I know Jean mentioned she was interested specifically on
the life decision.
About
there are lots of good documents available. I also encourage you, Alzheimer's Association had a very, very good resource. It's a very good resources for end of life discussion for people with dementia. This is what I use it as well myself in my clinic as well for people with dementia. I encourage you to go to Alzheimer's Association website. You can call them as well. They will mail it to you, any material related to end of life discussion for dementia people. It's a very good organization and they have a lot of good resources.
Thank you so much. All right, I think that's it. And we are coming up on time. as it is now. So thank you again, Dr. Ayati, so much for joining us and for this whole past year and being able to join us with all these town halls and all the information that you've been able to give us. So thank you so much.
Thank you for having me.
Yeah. All right, everyone. I did want to make one last announcement just to let you know that we are done with our town halls currently. Now we are moving on to the Avenidas Care Forum. So let me go ahead and share this.